with a general overview. I'll talk about ADHD's clinical signs in adults and some of its reflections, and then I'm going to talk about comorbid situations and treatment management in comorbid situations. I'll also try to give you some tips about each of these points. Now, we know that ADHD manifests itself with hyperactivity, impulsivity, attention problems, manifests during childhood, and it's a neurodevelopmental disorder. In earlier stages, when we started diagnosing ADHD, we initially thought that it was specific to childhood, but we know that ADHD doesn't simply stop with the end of childhood. 50 to 60% of the signs can continue into adulthood. And when we look at the ratios, in childhood we have 10-12%, in adulthood we have 4 to 5% of prevalence of ADHD. Now, Arzu talked to us about the stigmatized child in school. So what happens to that child when he or she becomes an adult? What kinds of problems do they encounter? And in some cases, in a very controlled and structured environment, ADHD might remain latent, but with an increase in responsibilities brought by adult life and the obligation to deal with those situations alone, it surfaces. And some people say, well, or rather they appear as adults who behave more like an adolescent or a child. Hyperactivity, lack of attention, and impulsivity actually are transformed somewhat in the transition to adulthood, and they lead to some difficulties in executive functions and emotion regulation. I'm going to focus on very practical points about emotional regulation and emotional control related problems experienced by adults with ADHD. But let us have a look at the signs and symptoms as they go through from childhood to adulthood. In the child, attention problems appear in boring environments. For the most part, they have difficulty keeping attention up, unable to listen, follow, completing homework takes a lot of time, and they make simple mistakes. When it comes to adults, quite often they complain that their attention is disrupted with unimportant affairs and a lack of organizing and ordering things. So organization and planning difficulty is what we have. They have difficulties making decisions, managing time. They forget things such as documents and bills, etc. They are more inclined not to complete tasks, and they keep delaying certain responsibilities. And in connection with this, they can also be inclined to refrain from taking on additional tasks or responsibilities. If hyperactivity and impulsivity signs continue into adulthood, it can manifest itself as restlessness in meeting environments, or where you would have individuals where they need to sit down. They are unable to do so comfortably. They're always on the move, always moving around, wiggling, and in a general restless state, and they can have difficulty following speeches and listening to people. In places where they need to wait in line, they're usually impatient. They have difficulty queuing. Their inhibition threshold is very low. They are more inclined to interrupt others when in a discussion environment, and they usually are engaged in risk-taking behavior, reckless driving, fast driving, and of course they can have frequent issues with traffic bills. Basically, hyperactivity disorders tend to go down. The same applies to impulsivity signs, but attention-related issues now take the center stage when going into adulthood. These three findings or symptoms, lack of attention, hyperactivity, and impulsivity. In addition to that, these individuals also have problem with emotion regulation, and emotional imbalance can turn into a low inhibition threshold, bursts of anger in impulsivity, and roller coaster swings in their mood, as you see from the picture. They can display excessive reactions to emotional situations. Now, we talked about the stigmatized child. In the adult stage, it becomes a problem individual or a problematic individual. A subpar capacity and work performance can occur. Economic issues, financial management can be a problem for them. Behavior issues, since there is no mood regulation, and bursts of anger. They also experience interpersonal problems. They have excitement-seeking behavior and impulsivity, which leads them to confront certain legal challenges as well. So life gets really chaotic for these individuals. Now, there is a very recent study about this exact point of disability and ADHD. In this study, compared to the control group, adults with ADHD talked about certain things significantly more, that they get engaged in fights more, for instance, that they have good relationship with their parents, or rather not so good relationship with their parents and their peers, that they experience problems in these relationships, so they are actually losing friends in the process, as reported by themselves. Now, for these individuals, shopping is not fun at all, because they have to wait in the queue to get to the cash register, and they get bored when doing so. In connection with impulsivity and mood swings, sometimes in order not to embarrass themselves and not to behave inappropriately, they might be inclined to escape from certain situations and environments, as reported by themselves. Now, when we talk about signs and reflections, let's have a look at comorbid situations and the differential diagnosis in certain disease conditions. We know that adult ADHD individuals would end up with another psychiatric disease 80% of the time during their lifetimes, and the most frequent one is mood disorders. But we have a problem at this point, because when we look at the symptoms of mood disorders, is it really a comorbid situations? Are these signs and symptoms of ADHD rather, because we know that those individuals might have mood regulation issues, or is it a reflection of the disability that is experienced as a result of ADHD? Now, a couple of minutes ago I was saying that they are more inclined to refrain from work because they are unable to complete tasks and fulfill responsibilities. So starting from childhood, they faced failure in their lives, and as a result they have low self-esteem, and generally speaking they're unhappy. So it's not that precise and clear for us. The boundaries are very difficult. With depression, bipolar, or borderline personality disorder and similar disorders sometimes have overlapping signs and symptoms, but of course some signs and symptoms are specific to each of these conditions. Overall, it's very confusing. But when we look at the comorbidity levels, depression, anxiety disorders can go up to 50%. Personality disorders can also go up to 50%. Borderline personality disorder, we have rates of 13 to 35% according to different studies. Now, let's have a look at each of these diseases one by one. Low self-esteem, irritability, and lack of attention are common symptoms of ADHD and major depression, but there are also different symptoms specific to each of these. Family history, onset of age, course, and symptoms are different in these two conditions. ADHD's family history is much more marked, and to get an ADHD diagnosis, symptoms need to start before the age of 12. And we're talking about a lifelong course. It continues into adulthood, and functionality is actually impaired throughout the lifetime. In depression, the onset age is 20 to 30. It is episodic in terms of the course, but it can also be chronic. Depressive episodes can become repetitive, and degradations in functionality are limited to these episode periods. Another difference has to do with symptoms. We because when we look at the diagnosis criteria of major depression, we have thoughts of that and pessimism, etc., but these do not apply for ADHD. Now, the results of comorbidity between ADHD and major depression that leads to an earlier onset of depression, sleep problems, changes in appetite, and attention issues can be areas where you can have more severe problems. Treatment management becomes more difficult, and we are faced with more significant disability as a result. Now, as I was saying, we're talking about up to 50% of comorbid situations. Now, there are certain theories that would explain these very high comorbidity rates. Genetical tendency might explain this. SNAP25 gene is usually called into question when we talk about this predisposition, and depression might also develop as a result of ADHD because there are certain failures that accumulate starting from childhood, inability to fulfill responsibility, feeling insufficient and incomplete, and low self-esteem, and a general situation of unhappiness can lead to major depression. But which one is more predominant? Now, the studies have shown that in this comorbidity, genetical and environmental factors need more explanation by longer and more comprehensive studies. Let's have a look at ADHD and bipolar disorder. We have impulsivity, extreme movement, distractibility, irritability, a lability in mood are some of the common signs and symptoms. But there are also some key differences. We know ADHD onset during childhood and it's continuous. In bipolar disorder, however, it's in early adulthood and it is cyclical in terms of the process is concerned. In the mania period of bipolar disorder, we have grandiosity, lessened requirement for sleep, and bursts of increase in productivity. These do not happen in ADHD. In ADHD, just as the opposite of grandiosity, we actually have an issue of low self-esteem. These individuals usually appear very concerned. It's not like bipolar disorder. They do not have bursts of increase in productivity. So what would happen in the comorbidity of these two conditions? Especially for bipolar purposes, we have an earlier onset, about 5 years or so. Depressive and mixed periods are more frequent, and euthymic periods are shorter. Anxiety, alcohol, and substance abuse disorders are more frequent. Legal problems and negative life events also become more frequent when you have these two conditions comorbid to each other. Let's have a look at borderline personality disorder. There are certain symptoms of this disorder with ADHD. It's chronic, it has affective lability involved, and impulsivity again is a common point. These individuals are more prone to taking risks similar to ADHD, but there are also differences. Repetitive suicide attempts, self-harming behavior, or that feeling of emptiness that is part of the diagnosis for borderline personality disorder are not part of ADHD. The most important difference is in a lack of attention, which is not a main symptom of borderline disorder. Neuroimaging studies, when they were reviewed, actually revealed something about these two conditions. These two conditions actually target a common area in the brain, or rather they point to a loss of functionality in the region of the brain. And this region of the brain is the orbitofrontal cortex, which regulates mood and emotions. Now, when we look after looking at comorbid situations and differential diagnosis, let's now have a look at the management of therapy in comorbid situations. Now, it is actually a very tough process. As you see from the picture, getting to this very nice view, getting to an open area, you have to go through paths and alleys that actually twist and turn. But the target is to achieve a balanced mood, increase social coherence, reduce legal problems, and assure anger management. Now, in ADHD, ADHD and bipolar disorder comorbid situations, stimulant therapy increases rapid cycling situations according to a general opinion. Can you wrap up, please? Okay. Stimulant therapy actually doesn't lead to as dramatic conclusions or results as some have suggested. The first intention is to treat bipolar disorder, and mood balance needs to be ensured in the first place. Once that's done, if ADHD symptoms have medium to severe impact on the life of the individual, then stimulant therapy can be initiated. If bipolar disorder symptoms occur during ADHD, again you can stop stimulant therapy and ensure emotional balance. So going back to that point. With depression, there are combined therapies. Antidepressant plus psychostimulant combination can be done. The noradrenergically effective medication takes the center stage in antidepressants because they help with reducing symptoms of ADHD. In addition to pharmacotherapy, cognitive behavioral therapy has also been shown to be beneficial. ADHD plus borderline, we focus on ADHD functions, mood swings, day-to-day functionality, stress management, behavior control, and psychotherapy process are all effective for the better. So ADHD treatment takes the priority at this point. So key points, take-home messages from this presentation are as follows. Continuous emotional imbalance, bursts of anger, and continuous irritability. If those are the complaints in an adult, can we have an underlying ADHD? This question should come to our mind. Once we do that, we should go ahead into the detail of diagnosis, differential diagnosis, and additional diagnosis. And once that's done, in necessary situations, medication combination can be used to sustain therapy. As a conclusion, individuals with ADHD have very complicated and chaotic lives, so we have to be very careful about this condition. Thank you.
We may take only one question, and then we will continue with the next speaker. Dr. Anathan, please.